Yes, sir.
Uh, Good morning. I welcome you all to this, another interesting session, and we have an iconic personality in diabetes to deliver this talk, Professor John Buse. I'm sure you have heard him and you have known him for a long time. John Buse has been the past president of ADA way back in 2008. He is currently Chief of Division of Endocrinology and Director of Diabetes Center at University of North Carolina, and he is also Director of North Carolina Translational and Clinical Sciences Institute. He is a speaker par excellence and is a great scientist and a brilliant speaker. So over to John for your talk.
Thank you very much. Um, can you see my slide now?
Yes.
Yes, we can.
Very good. So it's a pleasure to join you today and to talk about real world evidence and pharmacoepidemiology studies. Undoubtedly, you've seen many, many publications, some of them with very controversial results, some with reassuring results. And what I hope to do is convince you that this is a very important area of science moving forward, and that there are great opportunities for improvement in methods to provide new insights. Here are my disclosures. Our unit does a great deal of contracted work with the pharmaceutical industry, and listed here are sponsors of various activities. So what I'll start out with is what is real world data and what is real world evidence. They're a bit different. We'll talk about the strengths of real world evidence, particularly in contrast to clinical trials. I will give you some examples of real world studies that our unit has been involved in and other investigators as well. And then I'll summarize with some sort of hopeful comments for how we can, as individual clinicians, learn to interpret these data in a better way, but also where the field of real world evidence is likely to go in years to come. So I want you to think about our patients, and here you see depicted an elderly woman who's sitting in front of half a dozen or more different medications that she's juggling in her daily life. For us as clinicians, it's important to understand what the potential benefits and harms are to medications as we prescribe them. And this woman, as an example, is not very well represented in clinical trial data. So most clinical trials exclude the advanced elderly. Often they exclude patients that are on complex medication regimens. And one of the big advantages to real world data and real world evidence is it allows us to understand better what outcomes might be for someone like this woman. So real world data is data derived from the real world. And the best example of it is routine healthcare, clinical or business operations data. These are observations made in the context of free living humans, absent the complexities and sort of channeled activities of clinical trials. And real world evidence is evidence that's relevant to the real world. It's not necessarily true that all real world data provides us real world evidence. We need to manipulate real world data to really provide real world evidence. And real world evidence usually starts from real world data. So this is a beautiful slide I got from Kamlesh Kunti, looking at the continuum of clinical research. And at the bottom left, you see registration randomized clinical trials. We usually consider this sort of the gold standard of how we evaluate the efficacy and safety of a product. But recognize that that population is very constrained by inclusion criteria, and the endpoints that are being evaluated. And as we go to observational real life studies, including data from registries and pragmatic trials, we are expanding the scope of the population that's involved. But it's only really as we go to uh, truly observational data, retrospective analyses generally of large data sets that include information about clinical visits, medication prescribing, outcomes like whether a person had surgery or died, and the most um, generalized observational data analyses are ones that are unfettered by our presuppositions. So techniques like machine learning and predictive modeling that are just now evolving. So we have a spectrum of data, and each has its advantages and disadvantages. So in randomized clinical trials, we use these to determine efficacy, or the extent to which an intervention does more good than harm under ideal circumstances of administration of the trial product and collection of data. In real-world evidence, we have more information about effectiveness, which is the extent to which an intervention does more good than harm when provided under the usual circumstances of healthcare practice, including problems like non-adherence. Health economics looks at the efficiency of intervention, so the incremental cost related to a unit of quality or life gained or lost. But recognizing that the efficiency might be different from the patient's perspective versus a payer's perspective. So real-world data are data that are collected outside the control constraints of a conventional randomized clinical trial to evaluate what's happening in normal clinical practice. It is increasingly being applied in regulatory decisions and is being published more and therefore affecting our prescribing habits. So the randomized clinical trial really asks the question, can this intervention work? Whereas real-world data gives us more insight into whether the intervention does work in usual clinical practice. So let's talk about the strengths of real-world data and real-world evidence as compared to clinical trials. So the traditional randomized clinical trial in the left column is the established gold standard for regulatory purposes. It reduces the risk of confounding by the process of randomization. It provides a very detailed and comprehensive data set, including surrogate markers and laboratories, and the outcomes and events are generally adjudicated and validated. On the other hand, to answer a single clinical question is very expensive. These cardiovascular outcome trials, as an example, cost hundreds of millions of dollars and take from planning to execution and reporting 5 or more years. The effects are bounded by the sample size and statistical assumptions, and the population is generally narrow based on the inclusion and exclusion criteria, and therefore there's limited generalizability to broader populations. On the other hand, real-world studies in the right column are increasingly being accepted for safety monitoring by regulatory agencies. They're not cheap, but they are more economical than randomized clinical trials, and it allows us to look at health-related outcomes and resource utilization on a large scale, particularly in health economic analyses. They are very informative with regards to effectiveness in routine clinical practice, but they have serious limitations. We cannot infer causal relationships between treatments and outcomes. There are ways to get towards that. Requires very sophisticated methods to control for residual confounding, and it cannot, no matter how hard we try, with various sensitivity analyses and things like that, we cannot exclude residual uncontrolled confounding factors. Um, there are some studies that are flawed in that a small population or a biased data set may be used, and the data are often limited. Specifically, lab data are often not available in claims data sets, but we can make adjustments for that. And the assessment of endpoints or outcomes can be inconsistent or unreliable because there's a lack of adjudication. But again, we can make efforts to enhance that process of making outcomes more reliable. So for the kind of pharmacoepidemiology studies that are so common today, the advantages are large sample sizes, so generally hundreds of thousands or millions of people. The population is unselected. We have almost ideal data with regards to outpatient prescribing, at least when claims data are available. We can evaluate clinically relevant outcomes like hospitalizations and in some data sets, death. The ability to answer a question now is excellent because in general the data are already collected. It's just a matter of getting an appropriate data set and doing the analyses. But we often have a lack of information on certain covariates. Sometimes it's hard to validate outcomes, and we make our strongest efforts in limiting confounding with regards to why a particular patient got a particular drug versus an alternative choice. So to look at this and sort of wrap up the advantage of real-world evidence on the right versus the randomized clinical trial on the left is you could imagine that a population of patients in a clinical trial have some people who may derive benefits in green, and some people who may have harms in red, and some people who have equivocal responses in purple. But at the end of the day, when we get the results of the randomized trial, we have an estimation of the average treatment effect, which is really a combination of people who did well and did poorly. On the right, the advantage is that in this heterogeneous population, because of the large sample size and ability to do a variety of sensitivity analyses, we can hone in on populations that do benefit and populations that are harmed and populations that have an equivocal response. So the problem that we face today with regards to real-world evidence that's available to us in the form of publications is that there are some techniques and methods that are relatively simple and can be banged out quickly by a research team, but often they're just wrong. And the best kinds of real-world evidence really involve very complicated analyses, multiple sensitivity analyses, and alternative approaches. They're time-consuming, expensive, and require substantial expertise. And sometimes we really don't know whether they're right, but at least there's greater assurance through these kinds of techniques, though they're complicated, that they are in fact correct. So I want to give you an example on how I started in the field of real-world evidence. That came about after the reports about 10 years ago that glargine was associated with excess cancers in various data sets from Europe. In those analyses, they compared patients treated with insulin glargine compared to patients that were not treated with insulin. And it was pretty self-evident to people, experts in the field, that there was likely confounding related to baseline factors. So as an example, one could imagine that particularly obese patients with type 2 diabetes might be more likely to be treated with insulin, whereas more normal weight patients or patients earlier in their natural history would be less likely to be treated with insulin. So when we use the the so-called non-active comparator new user design, comparing people on insulin to people that were not treated with insulin. There is confounding by indication is the language we use, and specifically here, obesity. And so when our group started to work on the question of whether glargine was associated with an increased risk of cancer, we decided to use what's called an active comparator new user design, which tries to eliminate confounding by indication here with regards to obesity, because really there shouldn't be much difference in the prescribing based on patient characteristics, at least in the time in question around 2008, for whether a patient was prescribed glargine or NPH. And just to put a stronger point on it, we could substitute on the left-hand side things that might confound the analysis, the duration of diabetes or insulin resistance. And on the right-hand side, instead of looking at cancer as an outcome, we could look at cardiovascular disease, mortality, any complication, or cost. So in an effort to limit confounding by design, we generally use what's called an active comparator new user design. And in this design, we insist that patients have a baseline period in the database where they had no past use of medication. And then we look to see when a treatment was prescribed. Some patients are using drug A and some patients are using drug B. We generally start the follow-up period for outcomes at either the first prescription or the second prescription. The advantage of the second prescription, it suggests the patient is really taking the medication and not that they were just prescribed the medication, picked it up, and actually never really took the medication. And this is sort of analogous to the randomized clinical trial where we have a washout period, a randomization, and the randomization takes care of imbalances. Here, by using two active comparator drugs, we eliminate a lot of the confounding by indication or contraindication that would otherwise be involved in comparing patients on drug A versus patients that are not on drug A. So we still need to control for confounding and confounding by indication and contraindication by careful selection of the drug pairs. And we can try and evaluate whether patients, let's say with obesity, were more likely to be prescribed drug A or drug B. One of the ways that we do that is something called a propensity score, and if you've read these patients, you've certainly seen the concept of balancing cohorts based on a propensity score. And what a propensity score is really a probability of a patient being assigned to drug A versus drug B. And so if you think of a physician who's deciding whether to prescribe a patient, let's say an SGLT2 inhibitor, they will think of all kinds of different conditions that the patient may have with regards to whether they prescribe an SGLT2 inhibitor or another therapy. And for instance, in the CVD Real Nordic study, you see listed here something like 90 variables that are considered in the propensity score. So basically, you look at the patients that are prescribed an SGLT2 inhibitor, and in this study, as compared to a DPP4 inhibitor, you look at all these different factors, and then you weight the population so that at the end of this propensity score driven weighting, that the table 1 of the paper, the baseline factors, are aligned in the two treatment groups. And that's done as a statistical effort. So here we go. So now I'll go through a few examples of real-world studies. So the first thing that real-world evidence can do is address clinical questions that are not addressed in clinical trials. And this is my favorite example. So in the liraglutide development program funded by the manufacturer, they excluded patients with a BMI greater than 40. They evaluated the change in hemoglobin A1C in the light blue bars and the change in body weight in the black bars. There was no evidence with regards to the clinical benefits of weight reduction and hemoglobin A1C reduction in patients with a BMI over 40. And these investigators from the ABCD program in England were able to look at a broader range of patients, including substantial numbers of patients with a BMI over 50. And you can see that though we might have expected it, now we actually have evidence that, in fact, liraglutide is associated with even greater weight loss as in kilograms with the very heavy patients as compared to the patients with a BMI less than 40, and that the hemoglobin A1C lowering effect was similar to what was expected. So this was data not available in a clinical trial, provided through real-world evidence. Probably the greatest number of publications that we see in the real-world evidence space is to address safety issues that are often either unexamined or perhaps controversial findings that have occurred with the more limited sample size in clinical trials. Virtually every class of medications has been tagged with one or more of these kinds of safety warnings, and this is an example of an area that has been extensively examined both in randomized clinical trials and in real-world evidence, the question of whether pioglitazone is associated with bladder cancer. And some of the naysayers about real-world evidence really look to this area and saying, look, this effort is just useless because that pioglitazone perhaps is even protective for bladder cancer, and other studies with hazard ratios of 4.3 where obviously the implication is that pioglitazone is associated with a fourfold increased risk of cancer. The problem is a problem of methods and how these kinds of studies are conducted. And I would just highlight for you the most sort of iconic study, the Lewis study published in 2015 based on a registry which suggested near unity, very little signal for benefit or harm. And then near the bottom, the Dormandy study, which was a randomized controlled trial, the proactive study. But here you see on the right that there are a total of 20 events in the randomized clinical trial, providing a great deal of uncertainty as to what the true benefit or harm was with regards to bladder cancer. And in red, I've highlighted some of the studies that are methodologically most sound. These are not exclusively the studies that are methodologically sound, but I would just point out to you that in general, the studies that we have the greatest confidence with regards to the methods, the hazard ratio in general is greater than 1. So based on this, my take on it, though, bladder cancer is quite a rare outcome in diabetes and probably doesn't need to be a big part of the clinical decision making with regards to whether or not to prescribe pioglitazone. It is important for patients and providers to know that probably the best guess is that pioglitazone is associated with a modest increase in the risk of bladder cancer over intermediate timeframes. A more current and topical question is the issue of SGLT2 inhibitors and lower extremity amputations. And highlighted in gray is the Canvas study. Professor Neal was the first author. And there you see that the intent to treat analysis suggested about a twofold increased risk of amputations. And then we see a series of 4 pharmacoepidemiologic studies that came up with very different results. With one analysis suggesting a hazard ratio of 0.75, if anything, a reduction in risk, and another analysis suggesting a twofold increase in risk. Jeff Yang, a pharmacoepidemiology grad student at the University of North Carolina, published a paper in 2019 that looked at the methodologic issues that may define the differences. Why is it that some studies come up with a low hazard ratio and some studies a high hazard ratio? And I would just try and summarize that by saying that a huge issue is what the comparator is. Is it SGLT2 inhibitor versus no SGLT2 inhibitor? Here you see the data for an SGLT2 inhibitor being prescribed versus a DPP4 inhibitor. We think this is a great comparison. Relatively newer drugs that are branded and, at least in the United States, modestly expensive, that are used in similar populations, at least in the time frame that's examined here, which is up to, I think, 2017. And you see that here, the suggestion is it doesn't matter whether we do an as-treated analysis or an intent-to-treat analysis, what the grace period, latency, induction, washout, whether people are on baseline metformin or not, et cetera, then in general, the point estimate of the hazard ratio falls to the right side of 1, suggesting that there is an increased risk of lower extremity amputations with SGLT2 inhibitors as compared to DPP4 inhibitors. And if you look at this analysis from the same paper, on the other hand, if you do a comparison of SGLT2 inhibitors versus sulfonylureas, there seems to be no difference in outcomes. I would point out that in the patients that have a history of amputation as a baseline factor, or a history of chronic kidney disease as a baseline factor, with a smaller number of events, there's a suggestion of harms. Here in particular, if you include patients who only had one prescription and not two, this really drives the hazard ratio down. But remember, if they only had one prescription, we really don't know how much exposure there was. As a result, the uncertainty of exposure creates an uncertainty about the meaningfulness of the analysis. So the comparison is important, and then the details of how the analysis is conducted is important. So I'd like to switch to talking about safety issues that have been challenging to assess in phase 3 clinical trials. And here the question of diabetic ketoacidosis. So there were meta-analyses of clinical trials. Here, a meta-analysis of 72 trials that showed no increased risk of diabetic ketoacidosis across the trials, and efforts to statistically manipulate it further to increase the sample size further, again suggesting that there was no increased risk of DKA. And then an example of an excellent observational study, again using an active comparator new user design, where two drugs where theoretically a clinician would have almost a random chance of whether they prescribe a DPP4 inhibitor or an SGLT2 inhibitor, you see that there is clear evidence of an increased risk of diabetic ketoacidosis. Again, very rare outcomes. So we have 38,000 patients exposed to a DPP4 inhibitor here, and only, depends on which analysis, between 9 and 26 events. And again, with tens of thousands of patients exposed, relatively small numbers of events. But nevertheless, the suggestion is that the hazard ratio of diabetic ketoacidosis is in fact higher. And if you look at the most stringent analysis, so patients with 180 days of follow-up in patients that are not receiving insulin, so clearly they don't have type 1 diabetes, we still see a point estimate of the hazard ratio of 2.5. So this paper was published as a short report in the New England Journal in 2017, And finally, in 2019, we have clinical trial data from the DECLARE trial that diabetic ketoacidosis, in fact, probably is associated with SGLT2 inhibitor therapy from a randomized clinical trial. Fournier's gangrene is an extremely rare event, so on the order of 1 in 10,000 patients or less. We did an analysis in a data set called MarketScan involving patients between 18 and 64 years of age using the active comparator new user design, again with a relevant comparison of an SGLT2 inhibitor versus a DPP4 inhibitor, again insisting that patients have at least 2 prescription fills at the pharmacy. There were 210,000 people who could be analyzed based on these constraints. We use multiple different definitions for Fournier's gangrene, and you can see that some of them involve very few events, and some of them substantial numbers of events. But the good news is that the best evidence from this kind of pharmacoepidemiologic analysis is, though there's some uncertainty, the confidence intervals are pretty wide. In general, there's little evidence of harms as the point estimate of the confidence interval is less than 1. So in summary, well-designed real-world studies complement the data that we get from randomized clinical trials. But in our looking at these data as clinicians, we need to be aware of the kinds of real-world data. We need to think about the data sources and methodology, look for active comparator new user designs and the very careful cohort definitions, whether it's just 1 prescription or 2 or more prescription, and then sensitivity analyses that look at different subgroups and that there's consistency in the outcome. These methods have strengths and limitations, and it's important that the reviewers at journals push the envelope and make sure that investigators deal with this data appropriately. The methodologies for conducting these trials are improving, and increasingly we'll have more clinical questions being answered using this kind of data based on data linkages to improve controlling for confounding and using machine learning to reveal new insights. Thank you very much. I don't know the timing and whether there's time for questions or not.
Thank you very much, Dr. John. Can you listen to me?
Yes.
Yes. There are many questions which had come, but one very interesting question which had come from the India, many parts of the India, that quadruple therapy, we have a lot of real world data, but we don't have any real world evidence for using quadruple therapy. In India, many doctors and many practitioners we use in diabetic patients, even after 3 drugs, the insulin is not added, and quadruple or even more than 4 drugs as oral anti-diabetic agents are used, and we have real world data, but we don't have any real world evidence. What's your comment on this?
It's a great question. I wish I had a pen down here so I could write it down. So I'm sure we have a pharmacoepidemiology graduate student would like to take that on. I do think it's a great question. We know that using a drug as the first line therapy or the second line therapy, lots of clinical trial data, but you're absolutely correct. Taking patients that are on 3 drugs and then randomizing them to a 4th versus placebo, we have very little data, but we could address that in these real world data sets. Now, I don't have access to Indian data sets, but perhaps someone who does would like to collaborate with us to help you develop the methods to look at that carefully.
Thank you. One more about the real world data, the uses of SGLT2 in type 1 as well as in obese patient for the weight reduction, non-diabetic.
Yeah, so again, this is not something that, certainly not something that we have done. I'm trying to think, I do believe there is a paper out there on SGLT2 inhibitor therapy in type 1 diabetes, looking at diabetic ketoacidosis, suggesting that the risk is quite high, but I don't remember the details. One of the problems in many clinical data sets is that, as you know, many patients with type 2 diabetes that are treated with insulin, doctors have actually coded them as having type 1 diabetes, even though they haven't specifically looked to whether they have antibodies or their C-peptide is very low or unmeasurable. So these kinds of studies in claims data are difficult, but they're not impossible to do. Again, so my email address is on this slide, very easy to find on the internet as well. If somebody would like to pursue an effort, we can certainly try and organize some people
I'm
here
just
at
requesting
UNC to
you
help.
to stop the sharing of your slides so we can see more. You know.
There.
One last question: in US, what is the now currently the uses of pioglitazone and sulfonylurea? Because in India still we are using a lot of pioglitazone and sulfonylurea in real world.
Right. Pioglitazone is under 10% of, less than 10% of patients with diabetes now. The biggest concerns are, I think, the fluid retention, particularly in patients with advanced disease, and bone fractures. Sulfonylureas continue to be popular. I can't tell you the exact percentage, but probably 30% or so of the population with diabetes. It's the most commonly prescribed second line agent, more or less in a tie with DPP-4 inhibitors. Again, the major advantage to sulfonylurea is being cost, which I know is a big issue in India. It is a very big issue in the United States as well.
Thank you. We have your mail, and I'm sure we will be sending you many more questions. But now the time constraint, I think at 9:50, I request now Sanjay to take over. Thanks,
Well,
John. Thank you,
thank you for doing this. This is
organizer.
great.
Thank you very much. Good night.